We know that cardiovascular disease is very complex, and there are a lot of thoughts, a lot of, modalities which are available in management. So when it comes down to how do we approach the disease, the patients, the primary care provider, the cardiovascular specialist, all of them have to sit down and discuss the pathology and come up with a management protocol which is tailored towards particular patients. So it really should be a shared decision between the patient, the primary care provider, and cardiovascular specialist. So how can a patient ensure that they get the best care? So first thing in my mind is that, we should understand what are our risk factors. So when we're talking about cardiovascular disease, the most important risk factor are smoking, diabetes, hypertension, obesity, cholesterol abnormalities, family history, early onset coronary artery disease or early onset vascular disease, and things like that. So we got to understand our risk factors. And then we have to understand what the symptoms are. Many times I will see patients who have very vague, very atypical symptoms, but they are fixated on the fact that they truly have a coronary disease or they truly have vascular disease. That's usually not the case. So it is really important. So sort of the common symptoms which you should focus on, whether your blood pressure is poorly controlled, is it low, high, running all over the place? Are you having chest pressure, chest tightness? Is it squeezing sensation in the chest? Are the symptoms coming and going? Usually if it is a cardiac chest pain, you will not have constant pain 24 hours, 7 days a week. You will have intermittent symptoms of chest pressure, chest tightness, chest pain, usually exacerbated with exercise. What is your heart rate variability? Are you having very low heart rates, very high heart rates? Is there a trigger for rapid heart rate? Are you getting short of breath? Are you getting dizzy? Are you feeling more fatigued? Is your exercise capacity going down? Are you having swelling in the legs? Are you having leg pain, skin changes? And Craig just mentioned, about peripheral vascular disease, for example. So you have to understand your symptoms. And then based on that, you have to ask appropriate questions and emphasize on the symptoms when you're talking to your physician, okay? And I really want to emphasize that Dr. Google is not trained to diagnose and treat. So if you have met with your primary care provider or a specialist and you have a presumptive diagnosis, after that, by all means, do a proper literature search on that presumptive diagnosis. And I will really emphasize the fact that you need to use good resources to educate yourself on a disease process. So for cardiovascular diseases, for example, CardioSmart is a very good resource for the patients. Up-to-date patient portals are excellent resources for the patients. American College of Cardiology, American Heart Association, vascular societies, they have website portals for the patients where you can go and look for your symptoms, you can look for the disease, you can look for different tests and what you need to do. So use proper resources to educate yourself in managing your disease. All right, now let's go to the brass tacks here. So tests for coronary artery disease, and there are many, many, many different tests, and I've sort of categorized them broadly into non-invasive and invasive. So we have ECG, your calcium score, cardiac CT, echo, stress test, and we talk about invasive modalities. You have transesophageal echocardiogram and cardiac catheterization. If you're looking for tests for P.A.D, again, many, many different tests depending on what disease process you're looking for. The most commonly used tests are ankle brachial indices or toe brachial indices. segmental Dopplers, arterial duplex, carotid duplex, abdominal aorta aneurysm screens. If somebody has renovascular hypertension, you can look for renal artery stenosis. Somebody has venous disease, you can look for DVTs, you can look for reflux, you can look for pelvic congestion. And then, of course, if you have a suspicion for peripheral arterial disease, you can order CT angiogram or magnetic resonance angiogram. And then you have invasive modalities. We do angiography, we can use intravascular ultrasound. So let's talk about ECG. So ECG is a snapshot. It tells you what is going on at that moment. Sometimes you get information which is chronic. So say if patients may have had old heart attacks, or they have conduction disease, or they have some structural changes in the heart, those EKG changes are constant and we will always see them. You may have heard the terms like left bundle branch block or right bundle branch block or AV block. Those EKG changes we almost always see, and they are constant. So you may have a normal EKG, we have arrhythmias like atrial fibrillation, ventricular tachycardia, which can be quickly fatal, or you can have an acute MI where people are having a heart attack, and you can find out based on the EKG. So Kim wanted me to touch a little bit on atrial fibrillation. So really what AFib is an irregular rhythm of the heart. It's just the abnormal electrical circuits are usually coming from the pulmonary veins, which are entering into the left atrium. So the connection between the pulmonary vein and the left atrium, that's where these abnormal electrical circuits come from. And they usually overtake the circuitry of the heart, and you have irregular rhythm. So that's sort of the broad definition of atrial fibrillation. Couple of important facts about AFib. Usually there are, it's estimated that by 2030, 12 million people in the United States will have AFib. And it is a major cause of death, even in 2018. And people of European descent are more likely to have AFib than African Americans. So broadly speaking, after the age of 50, 1 in 3 people will have atrial fibrillation at some point in their life. So symptoms are irregular heartbeat, heart palpitations. You can have lightheadedness, dizziness, extreme fatigue, shortness of breath, and chest pain. And some of the risk factors for AFib are age, high blood pressure, obesity. 50% of patients who are obese will have atrial fibrillation. Talked about European ancestry, diabetes, heart failure, ischemic heart disease, thyroid dysfunction, chronic kidney disease, heavy and moderate alcohol use, smoking, and then if for some reason the left atrium of the heart is enlarging, maybe it's mitral stenosis, mitral regurgitation, pulmonary hypertension, what have you, then the stretch in the heart muscle can itself cause atrial fibrillation. And one of the biggest reasons that AFib is so morbid is that if the left chamber of the heart is sort of fluttering, there is an appendage where a clot can form, and that clot can literally go anywhere in the body. The most dangerous place would be that it goes into the brain and it causes a major stroke. That's why we have to be on the blood thinners when we have AFib. All right, so now coming down to coronary artery disease risk assessment. So if somebody is asymptomatic, younger adult, they have maybe some family history, maybe they are a smoker, maybe their cholesterol is not regulated. The easiest way to screen somebody for coronary artery disease would be to order a calcium score. Now, most insurance companies generally don't cover that, and it's a relatively cheap test to have it. I mean, we order it, but sometimes you have to fight the insurance companies to get it approved. But regardless, it's a relatively cheap radiology test, which can be done literally in 10 minutes. And what we are looking for is deposition of calcified plaque. And as the severity of the plaque calcification increases, you get more or higher calcium score. So if you have calcium score of more than 100, that puts you at a moderate risk of having coronary artery disease. And that's when you really have to get very, very aggressive in modifying your risk factors. So diabetes control, smoking cessation, lipid control. And if the calcium score is over 400, that's actually severe. And then usually if you have a situation like this, then we will recommend that the patient should have a stress test. So now let's say a patient has abnormal calcium score, they may have abnormal functional study, and then the question becomes, well, how can we figure out if there is an occlusive coronary disease? Well, one way, a non-invasive way, would be to order a cardiac CT angiography. And again, there are very specific insurance-based criteria which may not jive with our society guidelines, but this is the reality of medicine. But we can order cardiac CT angiogram, and it gives us a very good information on coronary anatomy, cardiac function. It can tell us if somebody has aneurysm. For example, here we can see an ascending aortic aneurysm. Here we have a thoracic aortic aneurysm. So we get very, very good information from cardiac CT scan. We can look at the valves. And nowadays, we can even do functional analysis of the blockages across the coronary arteries, and then tell the interventions, well, there is a lesion in LAD, for example, and the FFR on the CT scan is abnormal, and that lesion should be treated with a stent, what have you. Cardiac MRI is the same thing. Beautiful modality, and we generally use cardiac MRI for congenital heart disease when we are looking for some very specific structural abnormalities in the heart. For example, HOCM, amyloidosis, things like that, athletes. And here in this animation, you can see a cardiac myxoma, which is a tumor in the left atrium of the heart. And basically, I'm actually having a heart attack just looking at it because this is not good. So that's a model. Then we have echocardiogram, which is a very easy, widely available modality where we are using sound waves to create a live image of the heart. One of the most accessible cardiac diagnostic modality. And we get very, very good data on the structure of the heart, function of the heart. We can get good qualitative and quantitative data on the physiology of the heart. So we can make lots of diagnoses by just looking at the echocardiogram. For example, here you have a patient with amyloidosis, so there is some infiltration in the septum of the heart. The left atrium is a little enlarged. Here we have a patient with a heart failure. This is a patient who's had very severe MI and has got regional wall motion abnormalities. This is a patient with hypertrophic cardiomyopathy. This is a patient who has fluid around the heart called pericardial effusion. This is actually a very sick patient. So, from one test, you can make many, many different diagnoses. And sometimes you need a transesophageal echocardiogram where we put the probe inside the food pipe, and get very good images of the heart. And again, there are certain very specific reasons you want to do that. And one of the common reasons we do a transesophageal echocardiogram is to look for clots inside the heart, look at the valves, diagnose endocarditis. So here we have a patient with endocarditis or bacterial infection, which has colonized the mitral valve. See this thing flopping around? That's not good. Here we have a blood clot in the right atrium. which is about ready to go into the lungs and cause massive pulmonary embolism. And if, say, somebody has a hole here in the heart, this can go into the left side and cause massive strokes. Here we have a patient with heart failure, and they have a big blood clot in the left ventricle. So again, a very good modality to diagnose multiple different pathologies. Stress tests are used to figure out whether somebody has coronary disease. So the best stress test modality is actually exercise stress test, because you can get functional capacity, you can get information on heart rate and blood pressure response to the exercise. You can figure out whether a patient is symptomatic, they're having chest pain, and if that symptom correlates with any changes in the EKG. Does the patient have exercise-induced rhythm problems? So sometimes you can't use exercise stress tests for some reasons. Then we can combine the stress test with imaging modality, which could be echo stress test or nuclear stress test. And when we talk about just pharmacological stress test, where patient is not able to do exercise for some reason, then we can use drugs like dobutamine or Lexiscan and get similar information. And here is a patient with an abnormal stress test where the whole septum is basically ischemic, and this patient has a problem with the left anterior descending artery of the heart. Now, I really want to emphasize this, everybody does not need a stress test. So a lot of the times, patients are having non-cardiac surgery, and they will say, well, you need a cardiac risk assessment or cardiac clearance. As a cardiologist, I cannot clear somebody for surgery. I will only assess the risk of having a cardiac event during or immediately after the surgery. So that's my goal as a cardiologist. We never clear somebody for surgery. That clearing part is done by anesthesiologist and the surgeon and the patient. Now, if somebody is having a non-cardiac surgery, it's not a non-vascular, non-cardiac surgery, and that patient can do 10 metabolic equivalents of activity, they don't need any stress test. They can go ahead and get the surgery done. If patient is having non-cardiac surgery, but they can do 4 metabolic equivalents of exercise, which is, climbing a couple of flights of stairs, doing your regular household activity, mild, brisk walking, things like that, those patients do not need to have a stress test. So these are some important findings. So patients who may have had a known coronary disease, okay, so they may have had a stent, those patients do not need an annual stress test, not indicated. So generally we do a stress test in 2 years and then 5 years after CABG. Now, if somebody's having symptoms, then of course you will have to do a stress test. But for asymptomatic patient, and they have had, say, for example, CABG, there is no reason for do an annual stress test. So if patient is symptomatic and they have abnormal stress test, or they are coming in with acute myocardial infarction or non-ST elevation MI, then we do coronary angiography. And there are generally 2 routes to do a coronary angiography. One is the transfemoral route where we go through the groin, or there is a transradial route where we go from the radial artery. And nowadays we are actually going from the area between the thumb and your index finger. It's called the snuff box. We can even go put a little tube there and do the angiogram through that. So here we are looking at the right coronary artery, and here we are looking at the left circulation. This is the circumflex and the LAD. Now, one of the important things which you should know and you should ask your physician is, what are the risks of coronary interventions? What are the risks of coronary angiography? So these are relatively safe procedures. The risk of death when you're just doing plain diagnostic angiography is 1.1 in 10,000. Risk of heart attack is 0.2 per 10,000. So stroke is a little bit high, 5.9 per 10,000. Sorry, one second. Hello?
He's a doctor. He's on call. He is always on call. That's why
Can I
Dr.
call you
Gupta
back?
is
I'm
our
on a conference call.
patient
I'll call you back.
champion. So he's finishing up his discussion about angiograms. Angiograms can be performed both on the coronary as well as the leg arteries. And so some of the same tools, they perform angioplasty with a little balloon pushing the plaque to the side. They also have atherectomy that can be performed, which is the physical removal of the plaque using orbital, directional, laser, many different devices that they can use to do that. Right, Dr. Gupta?
Yes, yes. So, just, this is a list of risk of coronary intervention. So you can have bleeding, you can have infection at the catheter insertion site, you can have arrhythmias, post-procedure MI, post-procedure chest discomfort, the stents can close back up again, or there could be, in very, very rare cases, rupture of the coronary artery, which may require open heart surgery. So the bottom line for this slide is not to scare you, but to make you aware that there are risks. Anytime we do any intervention, there are associated risks. So you have to talk to your doctor and interventionist and understand what those risks are. Okay, now moving on to peripheral vascular bed, so carotid Doppler. So it's a very easy screening test which we can do to diagnose symptomatic carotid artery disease. It's just an ultrasound, very easy to do, and we get very good information. Again, what are the indications for carotid stenosis screening? Actually, the USPSTF does not recommend that we should screen routinely unless somebody has a history of stroke or TIA or dizziness. So if somebody is having some symptoms suggestive of carotid artery disease, then we should do the duplex studies. Many times people are ordering carotid Dopplers every year. We don't need that. That is not indicated. Okay. So unless or until you're symptomatic, then yes, you should get screened, but then it should not be annual screen. Okay. So that is important. Abdominal aortic aneurysm, very specific criteria for females who have never smoked. AAA screening is not indicated. Females who are more than age of 65 to 75, and if they have smoked, then they can be screened for AAAs. But the data to screen the women for AAA is very inadequate. So the guidelines say that it is an indeterminate appropriate use of AAA screen in these females. The men are a different beast. So anybody who has ever smoked, and if they are 65 to 75 years of age, then they have to be screened at least once for abdominal aortic aneurysm. And if people who have never smoked and they are between the age of 65 to 75, then based on other risk factors, these men could be screened at least once. Okay. Now, if they have AAA, if they have aneurysm, and the aneurysm size is between 3 to 3.9 centimeters, then you need surveillance ultrasound every 2 to 3 years. Okay. If the aneurysm is 4 to 5.4 centimeters, then you need it basically alternate between the ultrasound and CT scan every 6 months to 12 months. And once you are 5.4 centimeters, then you need to be evaluated for surgery. So very specific criteria for abdominal aortic aneurysm screens. Now, PAD, again, if somebody is over 65 years of age, has to be screened. Somebody who is a diabetic, smoker, has hypertension, hyperlipidemia after the age of 50 has to be screened. And the best screening for PAD, the most cheapest modality is ankle brachial index, which can be done at the bedside. You can have segmental Dopplers, which gives you a little bit of more functional data. And then you have your duplex sonography, where you get functional and structural information. And if somebody needs further testing, then you have your invasive or non-invasive modalities like angiography. You can do CT angiogram, you can do magnetic angiogram, you can do invasive angiogram. Again, it's very patient specific. You usually decide what modality you want to use depending on what's going on with the patient. So with this, I'm going to end, and I'll be happy to answer any questions.